go ahead and just put a little reminder out there. Please make sure your microphone is muted if it is not. Anna, feel free to start the recording if you have not already. And I'm just going to put a little note out there. I'm going to be sharing my screen to show you this presentation, so there's not really a whole lot else going on and much of a distraction. But on that note, if you have questions or comments, please try to hold them towards the end of the presentation. I won't be able to see the chat box, and I won't be able to see if you do that raise your hand option. I'm going to try to leave a tiny bit of time at the end so we can do some Q&A, and I will also have my contact info there if you need to reach me after the presentation. So on that note, I'm going to go ahead and share my screen. So please bear with me 1 second while I pull up that function. And we can get started. Okay, there's that crazy abyss. All right. And then actually, Anna, if you could unmute for a second, just let me know. Can you see the screen and see the slides changing?
Yep, looks good.
Perfect, thank you. All right, so thank you all for coming. Thank you and welcome. I'm very excited to share with you the research I found on the microbiome and anorexia nervosa. If you don't already know me, my name is Tad Taggart, UWGB dietetic intern, and I have a personal deep-seated passion for eating disorders and anorexia. I have a personal history here, and so I'm very invested in this topic. Definitely an area of interest in terms of when I become a dietitian. So I'm really excited to hopefully further some of the discussion here. So this is just the objectives, just an outline of where we're going. If you printed off the slides or if you saved the PDF, this will just be for your reference to kind of guide you, maybe to find information down the road. So let's start off. Let's make sure we're all on the same page in terms of anorexia. So it's diagnosed using the DSM-5, which is the most recent copy of the DSM. From the update from the DSM-4 to the 5, it was classified as a feeding and eating disorder, just some kind of change in nomenclature to make sure we're encompassing everything that this condition involves. And the diagnostic criteria that one must meet to be diagnosed with anorexia nervosa includes restriction of energy intake. This typically results in a body weight that's lower than expected based on age, sex, and height. So a very big part of both the diagnosis and the recovery and treatment process and setting goals for those with anorexia involves growth charts and growth trajectories. A very important part in this area. There's also an exhibited intense fear of weight gain or becoming fat. And this usually perpetuates into many different persistent behaviors that at the very least, aim to prevent weight gain and often result in weight loss. And then along with this, the individual usually exhibits very distorted body image, not recognizing the severity of the condition and not being able to recognize that even anything is wrong. So these are usually the diagnostic criteria we see. It's no doubt that it's definitely a very long and hard process in terms of recovery. Remission, let alone recovery, can take years. And that's only for those that are lucky enough to get the help they need and be able to actually achieve that. Unfortunately, anorexia nervosa is actually among the highest of mortality rates out of all psychiatric conditions. The #1 cause of death is organ failure from malnutrition. The second leading cause of death for those with anorexia is suicide. Unfortunately, depression is a very common comorbidity, as well as obsessive compulsion, anxiety, and a variety of different somatic dysfunctions, especially of the gut, but of other organs as well. The etiology, the actual cause of anorexia, isn't fully elucidated yet in the research, but all the theories that are combining right now are at least looking at a combination of genetic predisposition, environmental influences, some changes throughout the lifespan, particularly exacerbated during puberty, and then this development of poor coping skills around very stressful events and behaviors that kind of perpetuate into what we know as anorexia. And on the note of perpetuating poor coping skills and behaviors that don't really cope well with stress, stress is definitely a big component of the gut-brain axis, or excuse me, the gut-brain axis is a big component of stress and also implicated in anorexia. So if you're unfamiliar with the gut-brain axis, in a nutshell, it's this bidirectional communication or crosstalk between the brain and the gut. And there's a lot of different individuals, if you will, that come to the discussion here. So some of the bigger players includes obviously the brain, and more specifically, we're discussing the autonomic nervous system. So that's the unconscious parts of the body that are being controlled, right, by the nervous system. And even more specifically, we like to discuss the enteric nervous system, or the second brain, because it's such a complex network of nerves. And the vagus nerve is definitely implicated in the communication along the autonomic nervous system, particularly with the enteric nervous system. This is also the nerve that's related to respiratory function, heart rate function, all these unconscious functions we know of. And then in terms of stress, the hypothalamic pituitary adrenal axis is definitely implicated in stress response. So it's a very significant contributor to the gut-brain axis. At the gut, we have enteroendocrine cells. These are actually some of the biggest contributors and producers of hormones and signaling molecules in the body. If you didn't know this, up to 90% of the body's serotonin is concentrated in the gut, that happy hormone. Definitely really important in this whole communication process. And the gut-brain axis is also affected by the permeability of the gut, interestingly enough. So the gut's responsibility as part of us as a host to the microbiome, the bacteria, is to maintain a low permeability or a good lining to prevent essentially infection. And without that, as you'll see underneath the microbiome, we can have issues with immunity and inflammation, which actually has implications for this gut-brain axis. But then we also do know and confirm that the microbiome produces these metabolites of feeding on different dietary components that we eat. And specifically, we're looking at short-chain fatty acids and branched-chain fatty acids, which we'll discuss further. But they also contribute to the production of hormones and other signaling molecules that impact everything from mood to appetite. So definitely important in this discussion. If you need kind of a visual representation, I have this. I just made this, and I thought it was a really good way to visualize a more physical way of how this communication goes on, but that's for your reference. So in terms of the gut microbiome, we need to kind of discuss a little more specifically. That does encompass all microbes within the gut, but we're just concerned about the bacteria today. That's what we're going to discuss. And if you're unfamiliar with like taxonomic nomenclature, I have this table just for your reference. So if I throw around the term phylum, that's more of that general term of bacteria versus genus and species. We're speaking more specifically. The gut microbiome is very, very unique per person and very dynamic. So things like diet, physical activity, even medications can all cause changes throughout the lifespan, but we also see an interesting arc in terms of the population of the gut bacteria and the diversity. So early in life, infants are nearly stable sterile, at birth, and we see this increase in diversity in total population. But then, of course, we also know there's a increase in neurons and synapses and neurological development, which is maybe unsurprising. But what's more surprising is we see a very similar decline later in life. So as people age, there's a parallel in the decrease in diversity and total population of the gut bacteria and a decline in kind of neurons and synapses within the brain. Obviously, this is very different between people too, but it's just some sort of connection that some research is starting to see. And if I mention dysbiosis during this presentation, which of course I will, it's very relevant, just to make sure we're on the same page, that just refers to any change from baseline of the microbiome. So that can refer to total bacteria or specific types of bacteria, but any change that we'd be seeing from generally expected of normal, healthy baseline individuals. So a question that I don't necessarily need you to answer now or at any point, but even just something to ask yourself right now is something that maybe I want you to ask yourself: how did you come into this presentation? Did you see anorexia as a pathology of the brain or the body? And that will kind of like, I want you to use this as a reference for how you view the rest of this presentation and kind of chew on that for a little bit as we get going, if you will. So let's dive into some of the research, okay? This is just to help keep you on track where we're at. So study 1 was done in 2016. I know it probably seems a bit dated in terms of nutrition research, but definitely very relevant and actually points the direction for the rest of the research we're going to look at today, as well as research that's coming out down the road. Essentially, they just wanted to know, how does the gut microbiome relate to anorexia? You're going to find that the methods and the participants of the studies I'm going to use today are very, very similar. They're all observational studies, and in this case, they're all patients that are admitted to a hospital for weight restoration. All of these studies will take some sort of dietary recall or dietary information. All of them will do a stool sample because we need to look at the microbes in there. And all of them will also assess short-chain fatty acids within the stool sample. If you're interested in exactly how they assess the microbes, They do DNA PCR, and there's some additional steps in there for more detail, but I don't have time to get into it. That study in that bottom right corner is specifically one you can use if you're more interested in the nitty-gritty of that. So this is the only study that did a repeat testing at discharge. The other two studies only looked at admissions, so something to keep in mind and we'll discuss later. How did this study stand out also? They did a gastrointestinal questionnaire looking at lower GI and upper GI symptoms. So with anorexia and that gut-brain axis dysfunction, we know there's some dysfunction in the gut. Often in recovery, there's constipation, bloating, diarrhea. There's lots of issues that go on. We'll also discuss this further, but they kind of wanted to characterize this a little bit better and connect it to the microbiome. In terms of the participants that were involved, you're going to see the inclusion-exclusion criteria throughout these studies are very similar. In this case, we had 55 patients, 55 controls. The controls being essentially those without a diagnosis of anorexia and those with a BMI that's greater than 18. That's kind of our condition control. In this study, all of the participants were female. They took all anorexia nervosa subtypes, which means restrictive, where they eat very little, and then binge purge type. And there's a pretty wide range of ages that they accounted for. Exclusion criteria, they had to exclude anybody that was recently given antibiotics that would change the microbiome. They had to exclude certain diseases that might change gut function, that might change inflammation status, or might even change the microbiome itself. And they also had to exclude any individuals that might have a hard time complying with the study. So what did they find? With the patients, they had 44 matched sample discharge. The drop-off was essentially because there were a number of patients that developed really mainly respiratory infections, but other issues that they needed antibiotics. And then there were a few patients that discharged without follow-up. There was a mean increase in BMI of 2.3, but the weight restoration ranged from no increase in BMI up to 5 points. So really quite a gap. And I know this is a pretty general way to approach it, but this is the best way I can present it to you right now, is that just note that some of those lower GI and upper GI symptoms improved and some didn't. And I do have the more specific ones listed out here to kind of characterize that, but just keep that in your back pocket. The microbiome, these two are very big players in the phyla of the gut. There's the Firmicutes and the Bacteroidetes. And they noticed some very significant patterns here. So Bacteroidetes up in that top right corner was significantly lower in patients when they were admitted, and then interestingly actually decreased to a level of significance even further with weight restoration. So it didn't even resemble that of controls with weight restoration. And then similarly with Firmicutes, but on the other end, not increased to a level of significance at admission, but definitely higher, as you can see visually represented there, and then actually increasing further to a level of significance with weight restoration. So neither of these resembled that of the controls at discharge. And then more specifically, they wanted to hone in on this genus Methanobrevibacter, which is going to come up later, which is why it's significant. It was actually significantly higher in a majority of the patients at admission. And then this one actually did what we'd expect. It actually decreased and resembled that more of the controls towards discharge. So that was the kind of their microbiome results. In terms of metabolites, I know I have a lot listed here. I just want you to hone in over here, short chain fatty acids, note at admission for the patients lower, and then at discharge, restored for the most part, resembled that of the controls. Over here, butyrate is going to be a significant talking point for us today. You're going to notice it's quite a bit lower, and then actually surpassed that somewhat of the controls with weight restoration at discharge. And then total branched chain fatty acids were higher in the patients at admission and actually reduced somewhat, but still remained significantly higher than that of the controls at discharge. So some points just to note there. So what does this all mean? Number one, something to keep in mind is the microbiome remained different in these patients even at discharge. So remember those Firmicutes and Bacteroidetes didn't actually return to what we'd expect to look like for the controls. It actually remained significantly different even with weight restoration. And then even with those, with that butyrate, that's a really important point that we're going to discuss a little more at depth. And they attributed that reduced butyrate to be primarily due to this Roseberia species that's going to be of high significance. This is a very big butyrate producer in the gut, and it was significantly reduced in the patients, especially at admission. And then, like I mentioned, I want you to keep this in your back pocket. Those GI symptoms didn't all improve in the patients with weight restoration, kind of like we would hope, right? And this isn't fully characterized, but this next point might help us at least kind of understand it. Those branched chain fatty acids I pointed out, if you're unfamiliar with these are actually the metabolites of protein fermentation. So it's known that in the gut of these patients being admitted, there's a higher concentration of microbes that ferment protein. But the question to ask ourselves is, why would that be higher at admission if we know that patients with anorexia are consuming less? And that's because these bacteria are actually turning to degrade mucin, this really protective protein within the gut that maintains a good barrier of the gut. So without enough dietary protein, they're turning to mucin. But the problem is we're introducing this exogenous protein from the diet, and they're still degrading the mucin. So it's still causing this leaky gut and inflammation and dysfunction. So that may be a partial, at least, explanation of this gut dysfunction we're seeing. Definitely of significance moving forward. Okay, study 2. 1 year later, how did they contribute to the discussion? The one thing I want you to hone in on here is that they added that they wanted to look at psychological traits. So that's the major significance of this study. Very, very similar methods. This time they did blood samples and anthropometrics. I'm going to tell you right now, not very surprising findings, especially with the anthropometrics. And the blood samples, there's some discussion there, but it's not going to be relevant to today's discussion. Very similar again with the blood, the stool samples, short-chain fatty acids, but note the psychological assessments. We have the symptom checklist 90, which is just a general psych eval, the eating depression inventory, just as it sounds, as well as the state trait anxiety inventory and the Beck depression inventory. So those were the main psych assessments they performed. Participants were very similar. We had a lot smaller of a sample size, you might note. And then I also want to point your attention towards the BMI. Before in study 1, it was less than 18. This time it's less than 14. And I know in the nutrition world, we like to say that BMI is not a very good indicator. And in the healthy population, it's really not. But interestingly enough, it's actually a point of focus for anorexia, because we can't necessarily look at the actual standardized weight of every individual patient. So in terms of the research, at least, it helps us characterize the severity of malnutrition. And in this case, we can at least somewhat provide a blanket statement saying that these patients are probably a bit more malnourished. We're looking at a BMI that's quite a bit lower. Otherwise, exclusion criteria very similar, with the exception of they only wanted restrictive type anorexia, not binge purge, and they made the specification that they didn't want patients that recently had tube feeding. What did they find for the gut? They agreed with the first study that Firmicutes was lower, and then they even gave us very real numbers on that Roseburia being lower. Clostridium is also a subset of Firmicutes, and they again confirmed butyrate was significantly lower, as well as propionate, so those short-chain fatty acids are reduced. And then they also shared that gram-negative bacteria were increased in patients at admission. So note that the blue is patients with anorexia, the purple is the controls. So this like proteobacteria is a gram-negative bacteria, definitely higher. And they confirmed the bacteria DTs was also higher. They did some correlational studies too, mathematically, just looking at some relationships. They found that the lower the butyrate in patients at admission, the higher in severity they scored with depression and anxiety. So just some interesting relationships here. And then BMI, the lower these patients were in terms of their BMI at admission, the lower their short-chain fatty acid concentration in their stool. And then also the higher they scored on their psych parameters, especially with obsessive compulsion, depression, and anxiety. So how did they contribute to this overall discussion? They confirmed what study 1 found. They found higher Bacteroidetes, higher proteobacteria, and they found decreased Firmicutes. So they kind of doubled down on, yep, we're finding lower Firmicutes, especially that Roseburia and Clostridium genus. And this is a real problem because these are the butyrate producers. So this is kind of an explanation for that reduced butyrate. And butyrate is used as an energy source for many of the cells in our gut, and also helps contribute to that healthy barrier of the gut and general function. So an interesting connection is that other previous research has documented that individuals with IBD have also had lower levels of Roseburia. So there's some definite dysfunction going on there. And then another note, remember how I mentioned that those short-chain fatty acids do have an implication in the gut-brain axis and all that communication? This is just a really good shining example. Short-chain fatty acids actually help regulate peptide YY and GLP, which are really important appetite regulators, as you may or may not be familiar with. So there's definitely some implication that if we're dysregulating short-chain fatty acid production, we're definitely further dysregulating appetite regulation. And then to further exacerbate that, they confirmed that increase in gram-negative bacteria, such as the proteobacteria and Bacteroidetes. Many of these gram-negative bacteria have been known to produce a protein called CLPB, which is known to contribute to an increase in anxiety and a decrease in appetite, which are both things that we do not want in anorexia. Whether it's a cause or an effect, can't really say, but we're noticing some associations here. And then yet again, they confirmed that increased Methanobrevibacter species So I wanted to wait until now to discuss it because we know that with a second study confirming this, it has some significance. This is a methane-producing bacteria, and it's known to thrive in patients that are malnourished, individuals that have not been eating much and they're very severely in malnutrition. It is known to thrive with very low calorie diets, and it's at least thought in some early research to contribute to calorie harvest. So it may be thriving because it can survive with very low calorie intake and actually contribute to the survival of the host, in this case, the patients. And they at least contributed to the discussion that down the road there may be some implications that we can use BMI as both a predictor of how severe psychological traits may be, as well as the changes in the gut. So study 3. What does study 3 provide for us? This was in 2019, a bit more recent, and they wanted to focus on that functional dysfunction a little bit, or excuse me, that intestinal dysfunction a bit more. So they considered them functional intestinal disorders, FIDs. These are those conditions we know as heartburn, constipation, diarrhea, bloating, all of those different dysfunctions that, if you're familiar with the eating disorder realm, you may have seen in many of your patients. They wanted to characterize this a bit more and connect it to anorexia and the microbiome. And then you'll also notice in the title, they're also looking at patients that are admitted for tube feeding. So as I mentioned, that's part of the methods. Patients are admitted for enteral nutrition, still the same song and dance with the exception of looking at those FIDs and characterizing them via a Francis score. So the higher the Francis score, the more severe FIDs. Similar inclusion-exclusion criteria with that exception, that lower BMI, right? Sorry, they're in for tube feeding. So looking at the gut, they confirmed yet again that many of those gram-positive bacteria, those Firmicutes, were lower. You'll notice that on this chart, that Roseburia, right, enriched more in healthy controls, which means it's much lower in the patients. And I do just kind of, I don't have time to dive into the specifics of many of these different genus of bacteria, but do recognize that this study at least confirmed that there's a general pattern that the more dysbiosis we saw, the more that the patient's gut did not resemble that of the healthy controls, the more significant the FIDs. And I will give an example, but just understand that with the patterns you see here, that was pretty significant for FID, the gut dysfunction. So they confirmed yet again, there's definitely an increase in those pro-inflammatory gram-negative bacteria, definitely problematic for the gut function. They doubled down, tripled down, if you will, on the decrease in Firmicutes phylum, especially in that Roseburia genus. And then there's one genus they wanted to pick out, that Dialister genus was actually being increased and significantly associated with an increase in intensity of those functional intestinal disorders. And they did want to comment on this one specifically because previous research has associated an increase in this genus with those with IBS. So there's definitely some inflammation and dysfunction going on. There's really no doubt about it at this point. And this is really significant and needs to be a bigger part of the discussion, in my opinion. And I know that it's not exactly ignored, but I think it's going to be a bigger part of recovery coming down the road on how we can look at the microbiome in terms of using this for recovery. Because many patients will share, any individuals with anorexia will share that it's a big barrier to weight restoration and being able to eat if they're having gut dysfunction, which is probably not surprising, but this can often even lead to relapses and further restrictions. So it's going to have to be something we need to look at a little more closely down the road. And this study actually, in an off way, confirmed at least the correlational findings of study 2. So on their listed Mack et al. 2016 was study 1, and you'll note that at least the BMI was much more severe, and so was the dysbiosis. So we're definitely kind of still confirming that correlational connection there. And then I think as things are starting to go and we're noticing trends with gut dysfunction and BMI, we obviously can't say cause and effect, but there's this possibility that these microbiota are actually perpetuating some of the conditions of undernutrition. So if you think about it, right, the bacteria are living organisms, and if they are populating well within the malnourished state of those with anorexia, they're going to want to keep that malnourished state. So there's this very real possibility that they're actually perpetuating undernutrition, and they're perpetuating some of these dysfunctions, kind of like in the example of the Methanobrevibacter. It actually prefers the low-calorie environment, and it's actually thriving there. So there's just some implications there, and there's some connections with the blood samples that especially this study drew, that if you want to kind of connect, especially with like liver dysfunction and some of the cells of the gut dysfunction with the population of specific bacteria. These studies definitely have their limitations, very small sample sizes in all of them, 110 being the greatest. These are all observational studies. We can't really say cause and effect. And on that note, with study 2, those correlational studies, they tell us relationships, but they don't tell us what's cause and effect, what's chicken or egg, what's actually happening. We just think there's a connection. Study 1 did look at weight restoration, but just like that question I asked you early on, and as you probably already got the hint, right, weight gain in anorexia is not the same as recovery. So we can't necessarily equate the changes in the gut microbiome in study 1 with recovery. We can only equate them with the physiologic, with the weight gain, not with the psychological component. I do want to mention that study 3, both a limitation and arguably a strength of study 3 was that all of the patients on average were tube fed 10 days before the stool sample was collected. Now you might say, oh, well, that's going to dampen their results, but also interestingly that they found such significant dysbiosis and connections with functional intestinal disorders despite those 10 days of tube feeding. And then last but not least, with all these studies, this is all only taxonomic info. In other words, we're only looking at what bacteria are there and how much, but we're not looking on a genetic level, how these bacteria are actually contributing to certain conditions. So that could be definitely an interesting look down the road. And a little extra research I want to kind of point your way, or at least a direction, if this is something that you're very interested in the field, kind of like I am. Marcy Evans is definitely a big hitter in the world of eating disorders in the gut. And she did a webinar for EDRD Pro in 2017, basically on this exact same topic. So I was really excited to kind of further discuss what research has come out since she made this point. A big part of her discussion was functional gut disorders, or as we were just calling them functional intestinal disorders, same conditions, different name, right? They have lots of different symptomology and conditions, but really no biological marker. And if you're familiar with working with individuals in the eating disorder realm, it may not be surprising to you to find out that almost 100% of those with eating disorders have a functional gut disorder. A big part of her presentation that I want to share with you was this interesting connection of how eating disorders can contribute to the development of a functional gut disorder, as we've probably seen with the research so far, but also how a functional gut disorder can contribute to the development of an eating disorder. And in my brain, I make this interesting parallel between the gut-brain axis, right, that bidirectional communication between the gut and the brain, and how we essentially see a parallel here going on. In terms of the eating disorder, we know that the changes in behaviors, changes in intake, essentially causes a dysfunction and discommunication of the nerves and the muscles of the gut with the brain. And unfortunately, this gut disorder that develops can actually continue on through life, regardless if an individual actually achieves what we consider recovery of the eating disorder. So it's very common to tell an individual, oh, it'll resolve as you restore weight, but unfortunately, even if the severity resolves, many times these gut disorders don't. On the flip side, a functional gut disorder can exist independent of an eating disorder and is actually considered a major risk factor for the development of an eating disorder. Because if an individual has these symptoms of indigestion, bloating, constipation, diarrhea, they may attempt something like an elimination diet, taking certain foods out that may be triggers. And unfortunately, this can contribute to very real feedback on whether they ate quote unquote right or wrong, because they're going to feel better if they take out certain foods, which may perpetuate into an even more restrictive diet to try and essentially try to feel better. And this can really easily spiral into an eating disorder and is a major risk factor. And Marcy Evans shared that little quote on the bottom there with you, and I thought it was very, very profound in this realm, simply because a big part of recovery from anorexia or an eating disorder is learning to trust one's body. And it's obviously much more difficult if you feel like your body's betraying you. So just an interesting quote I wanted to share with you. So where the heck does this all leave us? I just want to reiterate, remember that we're not seeing all of the gut dysfunction and the dysbiosis resolve with weight gain. Note that, right, the decreased butyrate is definitely a possible contributor, as well as that mucin degradation. We're seeing some associations with malnutrition and the psychological associations. I definitely think that future research as well as future treatments are going to focus more on this dysbiosis, the gut disorders, and hone in on more on what we can specifically do for these patients directly at the gut. So on that note, this is my last slide. I'm really close on time. I'm very sorry I run so close, but I don't have time to run through all of this. Just note that through the research I've been digging through, as well as that shared by Marcy Evans, these are some potential therapies if you work with individuals with eating disorders that are supported by Marcy Evans in her practice, as well as different research. And I've tried to at least outline some of the reasons and the explanations for why they may be possible. I am going to go ahead and so here's my contact information if you need me after the presentation at any point, and if you have the slides, you can always reach me that way too. I'm going to stop sharing.